Hey everyone, welcome to the ECG Interpretation Workshop. In clerkship, you're going to see a lot of ECGs. You'll be asked to interpret them. Because there are so many potential parts of an ECG to interpret, it can initially be overwhelming. But, like any skill, it just takes practice and it can be developed. I am a lifelong learner of ECGs myself. There are many approaches out there to interpret ECGs. There is no right or wrong approach of ECG interpretation. Find one that works for you. Some ECGs present themselves in more obvious ways, like the STEMI here. Hope you can see it. For other ECGs, you may need to spend more time to analyze each component in a systematic fashion to uncover its treasures. In a lot of ECG exercises, or even your preceptors, they often just give you an ECG and say, "Go, interpret it all." Yikes, here we go. Hold up. Let's prepare you for that with today's ECG opportunity. Let's get good at each piece one step at a time and really break it down. Medical education enthusiasts like talking about ways to decrease cognitive load. So my strategy to do this for you is to ask you to look for 1 to 3 specific things on ECGs at a time to get you to focus on and pay attention to certain parts of ECG interpretation. In this workshop, there are going to be 3 ECG practice sets. Set 1 is about features, meaning I'm going to ask you to focus on and address only the rate, rhythm, or axis, with a reminder to think about the history. Set 2 is about waves. We're going to look at the P wave, QRS complex, T wave, and the U wave. The third set are ECGs that ask you about the intervals, which include the PR interval, QRS width, ST segment, and the QT interval. Prior to each practice set, I'll be doing a mini teaching session to prepare you for success in that practice set. After each practice set, we'll have a chance to review the answers together. Once all 3 sets are done, I'll present you with a final ECG where you can then analyze all parts together. I hope you enjoy this workshop, and I think you'll find it a comprehensive review of all parts of the ECG. By committing to practicing interpreting ECGs, you can save a life. Please do note that depending on which resource or textbook you read, you'll find that ECG diagnostic criteria and parameters differ slightly between resources. The numbers chosen in this workshop are ones that have consistency across several electronic clinical resources, as well as selected because of their ease to remember. Let's begin. First up is features. Let's cover what we mean by features. History, rate, rhythm, and axis is what I mean by ECG features to note. Just as the history is a huge part in diagnosing a chief complaint, the history associated with an ECG is a very important part as it provides a context that will help you with interpreting the ECG. For example, symptoms such as exertional symptoms, syncope, chest pain, or dyspnea illustrate a clinical picture and will help you make sense of the ECG you're looking at. According to a paper in Circulation, there are certain chest pain history items that increase the likelihood of acute coronary syndrome. These are radiation, diaphoresis, exertion, and nausea and vomiting. As part of the history, it is useful to grab old ECGs to compare it with the current one to see what ECG findings are old or new. Another feature to identify on the ECG is the rate. One way to calculate the rate is to divide 300 by the number of large squares between 2 R waves. Some people like to use 300, 150, 100, 75, 60 as a memory tool for the number of large boxes. Another method is to count how many QRS complexes there are in a 10-second strip, and then multiply it by 6 to get the number of beats per 60 seconds, or 1 minute. When you take a typical 12-lead ECG, counting the QRSs from left to right, that is a 10-second strip already, so simply multiply it by 6. Next up is rhythm. Pattern recognition aids with rhythm assessment. However, specific pieces of information will also help. Rate, rhythm timing, meaning, is it regularly regular, regularly irregular, or irregularly irregular? The P wave, PR interval, and QRS complex. These are the features of normal sinus rhythm. Rate is 60 to 100 beats per minute. The rhythm timing is regular. The P waves are upgoing and have the same morphology. The P wave should be before every QRS, and there should be a QRS after every P in a 1-to-1 P to QRS ratio. The PR interval is 3 to 5 little squares, or that's 120 to 200 milliseconds, and the PR interval should be constant. As for the QRS complex, it would be narrow and less than 3 little squares, or less than 120 milliseconds. These are the features of normal sinus rhythm. The last item in the category of features is axis. The normal axis is -30 to +90 degrees. One tip is to look at leads 1 and AVF. If both are upright, the vectors are pointing towards 1 and pointing towards AVF. The average of these vectors will point in the direction of the normal axis area, which is bottom right in this diagram here. This is a normal sinus rhythm 12-lead ECG shown previously. In lead 1, the QRS is upright. In lead AVF, the QRS is upright. I can now draw my vectors on the axis diagram. In lead 1, it points towards the right. In lead AVF, it points down. And that's again because of the upright lead 1 and the upright AVF. It's going towards those two areas. The net effect is a normal axis. And that's it for the features mini-teach. You're now ready to tackle the ECG practice set. For the purpose of this exercise, we will not be exploring the history as a feature. Answer the questions on each ECG pertaining to rate, rhythm, and axis. I'll do a demonstration with you first, and then you'll get a chance to work on the practice set independently. ECG F1. Demonstration. What is the rate? What is the rhythm diagnosis? Alright, so for the rate, I'm going to do 300 divided by the number of large boxes that I see between two QRSs. Let's go over here and take this one. There's a QRS here and a QRS here. There are two big boxes between the two QRSs. 300 divided by 2 is 150 beats per minute. Alternatively, I can count the number of QRSs. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27. 27 times 6 gives me 162 beats per minute. It also looks like sinus rhythm. I see a P wave before every QRS complex. The P is upright in 2. The P is inverted in AVR. And I can see some P waves actually that are hidden in the T wave, giving me a camel hump appearance. But I do see the presence of P waves. So taken together, this ECG shows sinus tachycardia. Alright, it's time for you to practice. So pause the video right now and work on ECGs F2 to F11. And once you're ready, please resume the video and I'll review the answers with you. So please pause the video and work on ECGs F2 to F11. Oh hey everyone, welcome back. So let's review some ECGs. F2, what is the rate? What is the axis? What is the rhythm diagnosis? So the heart rate, I got 54. I see a right axis deviation. The rhythm diagnosis is a sinus bradycardia. So how I got the rate is I got 300 divided by 6 equals 50, or counting the number of QRSs, 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 times 6 is 54. Right axis deviation is because in lead 1, the QRS is pointing downwards. So the vector would point left in the axis diagram. And in lead AVF, the QRS is pointing upright. So the vector would point downwards in the axis diagram. This would give me the net effect of bottom left, which is a right axis deviation. And the rhythm is sinus bradycardia. I do see a P for every QRS, and all these P's look about the same. F3, what is the rate? What is the rhythm diagnosis? So the rate is about 60. It's a junctional escape rhythm. So how we can get that is QRS, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 times 6 is 60. And I almost see about 5 large boxes between the QRSs, roughly. 1, 2, 3, 4, 5. So 300 divided by 5 is 60. I see a P before every QRS, but please note these P's aren't upright. They're kind of upside down here. There's an inverted P here, an inverted P here, an inverted P here. This is a junctional escape rhythm. The junctional escape rhythm originates in the AV node, and junctional escape rhythms are usually 40 to 60 beats per minute, so this is in keeping with that. P waves can be before, during, or after the QRS. In this case, the P wave is inverted and occurs before the QRS. F4, what is the type of heart block? Rhythm diagnosis. This is a first-degree heart block. We see a prolonged PR interval where all beats are conducted through to the ventricles. the PR is greater than 200 milliseconds or one large box. So here's the end of my P. This PR interval is greater than one large box. F5. What is the type of heart block rhythm diagnosis? This one is a second-degree heart block, type 1 specifically, aka wanky back. Here is a 5:4 conduction ratio of 5 Ps to 4 QRSs. In second-degree heart block type 1s, we can see progressive PR prolongation with RR interval shortening until a QRS is suddenly dropped. So in lead 2 over here, we see PR, and then suddenly PR is getting longer, getting a bit more longer, and then there's a P. Whoop, no QRS, goodbye. QRS has dropped. Longer drop. PR is also really useful for telling the difference between Mobitz 1, Mobitz 2, and a third-degree heart block. In Mobitz 1, the PR interval will continually increase. In Mobitz 2, the PR interval stays constant. And in third-degree heart block, the PR interval varies. So that's a useful way in differentiating between those three. F6. What is the type of heart block rhythm diagnosis? This is a second-degree heart block type 2. We see a 3-2 conduction and then also a 2-1 conduction. So 3-1 means there's 3 Ps, 1, 2, this P is kind of hidden, 3 Ps, and only 2 QRSs, so that's a 3-2. And then moving on here to the right-hand side, I see 1 P, and then this P is hidden with the T wave, 2 Ps for 1 QRS. That means it's a 2-1 conduction. So this ECG is displaying both 3-2 conduction and 2-1 conduction. We see a stable PR, same PR, and then the drop. Again, PR tells you the difference between Mobitz 1, Mobitz 2, and a third-degree heart block. In Mobitz 1, the PR interval increases. In Mobitz 2, PR stays the same. And in third degree, PR varies. In second-degree heart block, what is going on is the block is usually due to the block at the level of the His-Purkinje system. F7. What is the type of heart block rhythm diagnosis? This is a third-degree heart block. There's complete AV dissociation. There's failure of AV conduction with independent atria and ventricles. The P waves aren't conducted and never produce a QRS complex. We see the Ps march through the QRS. Again, PR tells you the difference between Mobitz 1, Mobitz 2, and third-degree heart block. In Mobitz 1, PR increases. In Mobitz 2, PR is constant. In third-degree heart block, the PR varies. We can see the P wave marches by itself through the QRSs. F8. What is the rhythm diagnosis? This is SVT, or supraventricular tachycardia. We do not see any P waves. The electrical impulse is not coming from the SA node, but somewhere at or above the AV node, as the QRS complexes are narrow. F9. What is the rhythm diagnosis? This is ventricular tachycardia. We see wide complex tachycardia, and this originates from an area distal to the bundle of His. The ventricular rate is greater than 120 beats per minute in ventricular tachycardia. VT is categorized as sustained if it's greater than 30 seconds in duration. The three features of VT include AV dissociation, fusion beat, and capture beat. Alright, so what is AV dissociation? We covered that. It's kind of like the third-degree heart block thing. The P waves are at different rates than ventricular rate. The arrows seen in this ECG identify where the P waves are hiding. AV dissociation is an insensitive finding though. This is an example of a capture beat. This is when the sinus node captures the ventricles to produce a narrow, complex beat. So this is the capture beat over here. So in the case of VT, sinus impulses from above do continue to fire, but often arise when ventricles are refractory. But if properly timed, a sinus impulse may reach ventricles that are no longer in this refractory period, and then it captures that sinus impulse to produce a QRS complex. This is called capture beat, which has the same morphology as a patient's native QRS complex. This is almost pathognomonic of a ventricular tachycardia. The third feature of VT is the fusion beat. This is a hybrid beat that results from the ventricle simultaneously being activated by a re-entrant circuit of VT and by another focus. So another focus, a re-entrant circuit of VT, they mush together to produce this hybrid or fusion beat. This is also almost pathognomonic of VT. F10, what is the rhythm diagnosis? This is atrial flutter. It's a type of SVT caused by re-entry circuit within the right atrium. The length of re-entry corresponds to the right atrium size, resulting in a fairly predictable atrial rate of about 300 beats per minute. Ventricular rate is determined by AV conduction ratio, which is commonly 2:1, producing a ventricular rate of 150. We can also see some saw-tooth flutter F waves, and these are best seen in lead 2 and V1. F11, what is the rhythm diagnosis? This is atrial fibrillation. It's irregular, narrow complex tachyarrhythmia, and it's due to multiple micro-reentrant circuits within the atria. Ventricular rate is usually 100 to 180. We don't see any distinct P waves, but merely an undulating baseline of fibrillation F waves. Congratulations, you've reached the end of the features ECG set. Hooray! Next up is waves. The P wave. The P wave represents atrial depolarization, where the first half of the P wave represents the right atrial depolarization, and then the second half is a left atrial depolarization. The P wave is upright in most leads and biphasic in V1, inverted in AVR, and variable in lead 3 and AVL. In terms of the magnitude of the P waves, it should be less than 2.5 millimeters tall in the limb leads and less than 1.5 millimeters tall in the precordial leads. Too tall means right atrial enlargement. Too wide, in contrast, means left atrial enlargement, and it's often a notched appearance. The P wave should be less than 120 milliseconds in width, and that's 3 little boxes wide. QRS wave. For the purpose of the QRS complex or the QRS wave, we're going to be looking at the morphology of the wave itself. We're going to see if there's any pathological cues and how low or high the voltages are. The QRS width, whether it's narrow or wide, will be explored in the next section, the intervals. When we look at Q waves, we may consider them to be pathological if they're greater than 1 millimeter wide and greater than 1/3 the height of the QRS. QRSs can also be categorized whether it seems very tall or very short. Low voltage would mean that it's less than 5 millimeters in the limb leads or less than 10 millimeters in the precordial leads. High voltage could be a sign of left ventricular hypertrophy. One criteria of LVH is the S wave in V1 plus the R wave in V5 or V6 totals more than 35 millimeters, or 7 big boxes. Another LVH criteria would be the R wave in AVL is greater than 11 millimeters. Next up is the T wave. This represents ventricular repolarization. Normally, it's 2/3 the size of the R wave. T wave inversion is abnormal if seen in 1, 2, AVL V2 to V6. The peaked T wave, as in the case of hyperkalemia, is generally tall, narrow, and symmetrically peaked, like the one in this diagram. It's so tall and so peaked and so narrow that, ouch, if you sat on it, it would hurt. That's when you know that might be hyperkalemia. Then there's something called hyperacute T waves. This could signal early ischemia. There are 3 kind of hyperacute T waves I want you to be aware of. The first one is a new upright T wave in V1. This may indicate ischemia. Or there's a disproportionately large T wave in comparison to the QRS. There's a tiny QRS in comparison to that large T wave. And third, there's straightening of the upslope of the T wave. I'll show you some ECGs in the next few slides to help illustrate these things. This is a new upright T wave in V1. Generally, V1 has no T waves or inverted T waves. A new upright T wave in V1 may be a sign of ischemia if the patient has cardiac symptoms. So what are you going to do? You're going to repeat the ECG and see if there are any dynamic changes. Now this T wave in V1 is also pretty concerning because it's getting straight. This is the straightening of the upslope of the T wave, a hyperacute T wave. Maybe V2 and V3 are trying to get straighter too. We gotta repeat some ECGs to find out more. You can also see that the T waves in V2 and V3 are also concerning for hyperacute T waves, since the T wave is disproportionately large in comparison to the QRS. The QRS can almost live inside the roof of the T wave. You can fit that QRS under the roof of the T wave. And when we repeat the ECG, bam! It's a STEMI. So to summarize, here are 3 T wave findings that may suggest it to be a hyperacute T wave or an early sign of ischemia. Number 1 is a new upright T wave in V1 for patients who have symptoms. Number 2, the QRS fits under the T wave. The QRS is able to live under the roof of that T wave. And number 3, the T wave upslope straightens. The T wave is trying to straighten out. These 3 are signs of potential early ischemia, and they are hyperacute T waves. The U wave. So what causes the U wave? Here are some scientific theories. Delayed depolarization of Purkinje fibers, prolonged repolarization of mid-myocardial M cells, after potentials resulting from mechanical forces in the ventricular wall. Who knows? That's just for interest. Just know that the U wave is after the T wave. The normal U wave has a size that is about 10% of the preceding T wave, or less than 1.5 millimeters tall. Abnormalities in the U wave include a prominent U wave or an inverted U wave. The prominent U wave is defined as 5 millimeters or more, or as tall as the T wave. This can happen in bradycardia, hypokalemia, hypocalcemia, hypomagnesemia, hypothermia, left ventricular hypertrophy, and HOCM, hyperobstructive cardiomyopathy. Inverted U's are also abnormal. This can be seen in ischemic heart disease, hypertension, left ventricular hypertrophy, and long QT syndrome. You made it! That's the mini teach for the wave section. You're now ready to tackle the ECG practice set. We're going to be covering ECGs that include P waves, the QRS complex, in particular the Q waves in height, T wave, and U wave. So let's first do a demonstration. Out of P, QRS complex, T, and U, which 2 waves are abnormal and why? What are the ECG diagnoses associated with the abnormalities? So the 2 abnormalities are going to be the P wave and the QRS complex. First, the P wave is very tall. Look at this tall P wave over here in lead 2. Very tall. This is right atrial enlargement. Now the QRS is also very tall. Look at that. V1, V6. If you add the magnitude of V1 and the magnitude of V6, that's about 9 big boxes. Greater than 7 big boxes is about 35 millimeter or more. That meets criteria for left ventricular hypertrophy. Alright, now it's your turn. Please work on ECGs W2 to W6. And once you're ready, resume the video and I'll review the answers with you. Enjoy! Hey everyone, welcome back. Let's do W2. Out of P, QRS complex, T, and U, which 3 waves are abnormal and why? What are the ECG diagnoses associated with the abnormalities? For this ECG, there's an abnormal P, QRS, and T. The ECG diagnoses are left atrial enlargement, left ventricular hypertrophy, and T wave inversion. Let's start with the P. The P wave is wide. Look at that width of that P wave. Pretty wide here. This is consistent with left atrial enlargement. We can even see a bit of a notching pattern in lead 2. Looking at the QRS, it's also pretty high in magnitude in V1 and V6. Adding those 2 together is greater than 7 large boxes, so that's LVH. And finally, we see some T wave inversions in the lateral leads. Over here in V5, over here in V6. Specifically, we see ST segment depression, which goes into a T wave inversion. This type of pattern is called left ventricular strain pattern. We see this ST segment depression moving into a T wave inversion. and the left-sided leads. That's left ventricular strain pattern. This diagram is just to illustrate the atrial abnormality again. Left atrial enlargement is when it's tall, while left atrial enlargement is when it's wide. This is in reference to the P wave. This is another picture to illustrate that right atrial enlargement has tall P waves and left atrial enlargement has wide P waves. So why is that? The first half of the P wave is right atrial activation. The last half of the P wave is left atrial activation. In right atrial enlargement, since the right atrium is larger, it takes longer to depolarize, and the right atrial wave looks like it travels toward the left atrial wave and merges with the left atrial wave to form a bigger P wave. In left atrial enlargement, since the left atrium is larger, it takes longer to depolarize, and the left atrial wave now appears to gradually travel away from the right atrial wave a bit, and it looks like the P wave is lengthened. W3, out of P, QRS, complex T, and U, which one wave is abnormal and why? What two differential diagnoses can cause this? The T wave looks abnormal because it's large. The T wave is tall, narrow, and symmetrically peaked. Ouch, it hurts to sit on it. Peak T waves are from hyperkalemia in this case. The potassium was 7.0. While large T waves could also mean hyperacute T waves in early ischemia, especially if the QRS can fit under the T. Other potential looks of hyperacute T waves include a T wave where the upslope is straight, and the new upright T wave in V1 in a person with cardiac symptoms. W4, out of P, QRS, complex T, and U, which one wave is abnormal and why? What medical diagnosis can cause this? The Q waves in the inferior leads look pathological. This is an old MI. Inferior leads 2, 3, and AVF. Those are pathological Q waves in the inferior leads suggestive of an old myocardial infarction. W5, out of P, QRS, complex T, and U, which one wave is abnormal and why? What medical diagnosis can cause this? Looking at the QRS voltage, it appears pretty low. In fact, some are really, really low, and some are higher. You may even say that it's alternating. This is called electrical alternans. Some voltages are low, higher, lower, higher, lower. It alternates. The medical diagnosis this is associated with is massive pericardial effusion. We can even see sinus tachycardia throughout, and the massive pericardial effusion triad is actually a combination of number 1, tachycardia, number 2, low voltage, and number 3, electrical alternans. This ECG is suggestive of massive pericardial effusion. W6, out of P, QRS, complex T, and U, which one wave is abnormal and why? What medical diagnosis can cause this? This one is actually the prominence of the U wave. This ECG is from hypokalemia. A prominent U wave is 5 millimeters or more, or as tall as the T wave. Causes include bradycardia, hypokalemia, hypocalcemia, hypomagnesemia, hypothermia, LVH, and HOCM. So P, QRS, T, U. Look at this U wave. Very prominent. This is a diagram demonstrating the hypokalemia ECG changes. In mild hypokalemia, you get broad T wave flattening. In moderate hypokalemia, U waves appear with slight ST depression. In severe hypokalemia, U wave increases and fuses with the T wave, and then you can get a more pronounced ST depression as well. Congratulations! You've reached the end of the Waves ECG set. We're ready to cover intervals now. Let's talk about the PR interval. The normal is 120 to 200 milliseconds. This is 3 to 5 small boxes. We want to look for any short PR, long PR, or depressed PR. Short PR is in the case of pre-excitation, where there is a special pathway for the electricity to go through faster than the normal AV node route. Long PR suggests that there's an AV block, and it's prolonging the depolarization through the AV node. And finally, depressed could be a sign of pericarditis, but please note that depressed PR could also mean atrial infarct. QRS width. The normal width is 60 to 110 milliseconds. When we refer to intraventricular conduction delay, this means that the width is greater than 110 milliseconds. Bundle branch block is defined as a QRS width of 120 milliseconds, which is 3 little boxes, and a right bundle branch block or left bundle branch block pattern. In right bundle branch block, we see bunny ears in V1, whereas in left bundle branch block, we see bunny ears in V6. So in V1, we see these bunny ears for right bundle branch block, and for left bundle branch block, we see these bunny ears in V6. And finally, there's something called the delta wave, which is depicted over here. It's the slurred upstroke of QRS as seen in Wolff-Parkinson-White syndrome, which is a pre-excitation syndrome. Let's move on to the ST segment. So what are we comparing the ST segment to determine whether it's elevated or depressed? We are going to compare it to the baseline, which is TP. At the end of T to the beginning of P, this is the baseline from which we compare whether the ST segment is elevated or depressed. We're going to look at the J point to see if there's ST elevation. The point of inflection is where the J point is. The point of inflection is when the curve transitions from one direction to the other direction. This is the J point. The STEMI criteria for ST elevation in V2 and V3 are as follows: 1.5 millimeters or more in females, 2 millimeters or more in males 40 years and above, or 2.5 millimeters or more in men less than 40. For all other leads, you just need ST elevation 1 millimeter or greater. As a reminder, to have a STEMI, you need ST elevation in 2 or more contiguous leads. When the ST segment looks frowny, it's sad, because it's bad and is suggestive of STEMI. Smiley is more likely benign, especially if there's J-point notching, in the case of early benign repolarization. J-point notching is depicted here, where the J-point notches. Here's a slide for reference that reviews localization of a STEMI. Inferior leads include 2, 3, and AVF. Lateral leads include V5, V6, 1, and AVL. Some note that 1 and AVL are actually high lateral leads. Septal leads include V1, V2. Anterior leads include V3, V4. Here's just another way of looking at the same thing for repetition. Inferior leads are 2, 3 AVF. Lateral leads include V5, V6, 1, and AVL. Septal leads V1, V2. Anterior leads V3, V4. Here's a mnemonic that will help you remember where the reciprocal changes should be. PALS helps us determine where the reciprocal changes should be. How PALS works is if there's a posterior STEMI, you're going to have anterior ST depression. Anterior STEMI means you'll have inferior ST depression. Inferior STEMIs, lateral ST depression. Lateral STEMIs, septal ST depression. Septal ST elevation means, you go back to the beginning, posterior ST depression. So the letter that follows the previous letter is the reciprocal change of that previous letter. PALS. And the QT interval. Visually, the QT should be less than 1/2 the RR interval. The normal QTC in men is 390 to 450. In women, it's 390 to 460. I often use the digital printout of the QTC and find that to be overall accurate. Long QT syndrome is defined as 500 or more, or 480 or more in a patient with unexplained syncope. Short QT syndrome is a QT interval of less than 330, or less than 360 and 1 or more of pathogenic mutation, family history of short QT syndrome, family history of sudden death age less than 40 or equal to 40, survival of VT or VF episode, and absence of heart disease. The mini-teach for intervals is now complete. It's time to take on the ECG practice set. We'll be going over ECGs covering the PR interval, QRS width, ST, and QT. Let's first do a demonstration. Out of PR, QRS width, ST, and QT, which 2 intervals are abnormal and why? What medical diagnosis can cause this? Let's look at the PR interval first. The PR, to me, seems short. Look at that here. PR, very short. It's less than 120 milliseconds. I'm wondering if there's pre-excitation. QRS, to me, appears wide. And here you can see the slurred upstroke. This is called the delta wave. It does look like, in V1 and V2, a bit of an ST elevation, but it does look concave up, and I don't appreciate any reciprocal changes, so hopefully it's less likely ischemic. Also, the elevation is only about 1 millimeter from the baseline, which is TP. If the patient is female, the cutoff is at least 1.5 millimeters for V2 and V3, and if male, the cutoff is at least 2 millimeters for age 40 and up, and at least 2.5 millimeters for age less than 40. When looking at the QT, it looks less than 1/2 the RR interval. This ECG is actually an example of Wolff-Parkinson-White syndrome, or WPW for short. To diagnose WPW, the ECG findings are actually the following. Number 1, PR is less than 120 milliseconds, which it is. Number 2, QRS is greater than 120 milliseconds, which it is. And number 3, presence of a delta wave. And we do see that slurred initial upstroke of the QRS complex. There is a delta wave in this ECG. Now, even if you didn't know the diagnostic criteria for Wolff-Parkinson-White, by being systematic and going through the intervals, you'll be able to either look up what it all means or ask someone to help you piece it all together. Wolff-Parkinson-White, again, is a congenital abnormality where there's an accessory pathway of atrial tissue that bypasses the AV node and activates the ventricle early. That's why we call it pre-excitation. And tachyarrhythmias can occur because the pathway makes a re-entry circuit. So yes, looking at the lateral leads, there might be evidence of LVH. However, Wolff-Parkinson-White may mimic LVH, since a right-sided accessory pathway may direct depolarization towards the left side, amplifying the R-wave amplitude in V5 and V6, and also the lateral limbs of 1 and AVL. Time for you to practice. Pause the video now and work on ECGs I2 to I8. Once you are ready, resume the video and I'll review the answers with you. Hey folks, welcome back. Let's start with I2. Out of PR, QRS with ST and QT, which two intervals are abnormal and why? What medical diagnosis can this cause? I'm seeing PR depression diffusely in the precordial leads V2 to V6, the limb leads 1, 2, AVL, AVF, and reciprocal PR elevation in AVR. So we're seeing PR, for example, in lead 1 here, where TP is my baseline. TP, PR is depressed. AVR is kind of like a reciprocal lead to all other leads, and I'm actually seeing PR elevation over here in comparison to my TP as my baseline. PR elevation over here. The QRS width is fine, nice and narrow. There is ST elevation seen diffusely. I see it in the precordial leads V2 to V6, the limb leads 1, 2, AVL, AVF, and we also see some reciprocal ST depression in AVR. ST depression here. We see some ST elevations scattered throughout. And it's a concave type of smiley face elevation. The QT looks okay to me. Taking everything together, this is actually an example of pericarditis. But clinically, make sure you've ruled out all the life-threatening chest pain causes first before calling this pericarditis. I3. Out of PR, QRS with ST and QT, which two intervals are abnormal and why? PR looks okay. The QRS is widened, but why is it wide? Because there's a left bundle branch block. Notice the left bundle branch block morphology with the rabbit ears and the left precordial leads. Bunny ear, kind of bunny ear, and a deep S wave in V1 to go along with that. This is consistent with left bundle branch block. In terms of ST changes, I do see some ST depression in the lateral leads, in V5, V6, 1, and AVL. There's some ST elevation in the right precordial leads. So, could this be a STEMI? That's a good thought, and it's okay in this case. And why? It's because the QRS is in the opposite direction as the ST elevation. The QRS is in an opposite direction to the way the ST elevation points. This discordance is normal in the context of left bundle branch block. On the flip side, if there is a QRS in the same direction as the ST elevation or ST depression, this would be abnormal and could be an MI. In the same direction is called concordance, where they're in the same direction. There's criteria called the Sgarbossa criteria that can help you determine whether or not there may be a STEMI in the setting of a left bundle branch block. This is a review of what the left bundle branch block looks like. We see bunny ears in V6. Ta-da! The left-sided lead. This is the Sgarbossa criteria for identifying a STEMI in the setting of left bundle branch block. If there is concordance, this means that the QRS is pointing in the same direction as the ST segment, whether it be elevated or depressed. For any lead, if there is an upright QRS and an ST elevation, this could mean a STEMI since they are pointing in the same direction or concordant. For leads V1, V2, or V3, if there is a downwards QRS and an ST depression, this could mean a STEMI since they are pointing in the same direction or concordant. So to review again, Sgarbossa criteria helps you identify a possible STEMI in the setting of left bundle branch block. We are looking for any concordance. Concordance is bad. Pointing in the same direction is bad. This shows normal discordance. Normally, in the presence of left bundle branch block pattern, the QRS points in a direction opposite to that of the ST depression or elevation. Hold up, there's also an additional modified Sgarbossa criteria that looks for excessive discordance of greater than 25%. This means that in the presence of a left bundle branch block, there might be a STEMI if the ST elevation is excessively discordant of greater than 25%. Compare the ST elevation with the downwards S preceding it. In this picture, the ST elevation is 35% that of the S wave preceding it. This is excessive discordance and can be a STEMI with the right story. You just need to see this in any one lead. If you ever encounter ST elevation in the context of a left bundle branch block, you can always do an electronic search for modified Sgarbossa criteria to pull up the 3 criteria to double check your suspicion of a possible STEMI. Alright, moving on to I4. Out of the PR, QRS with ST and QT, which one interval is abnormal and why? PR looks okay. QRS is widened. So why is it wide? There's a right bundle branch block. Notice the right bundle branch block morphology with the rabbit ears in the right precordial leads. Boom, boom. ST looks okay. QT looks okay. Here's a picture of right bundle branch block characteristics. We see bunny ears in V1, which is a right-sided lead. Boom, boom, boom. Nice and tall. It can hear you very well. And then we have a slurred S wave in V6. I5. Out of PR, QRS with ST and QT, which one interval is abnormal and why? The QT, in this case, is greater than 1/2 the RR interval. In this case, the QT is prolonged because of hypomagnesemia. I6. What is the type of MI and why? This is more of an anterior septal MI, since we see ST elevation in V1, V2, V3, and V4. Or some may consider V1 to V4 more anterior leads and call this an anterior MI as well. I7. What is the type of MI and why? We see ST elevation in V1 to V6 and 1 and AVL. This is anterolateral MI. There's some reciprocal ST depression in 3 and AVF. We're seeing some Q waves in V1 and V2. I8. What is this type of MI and why? This would be an inferolateral MI with possible posterior extension. It's an inferior MI because 2, 3, AVF are involved with ST elevation. The lateral component is V5, V6, and 1 here that we see ST elevation. Note that in the anterior leads here, there is ST depression. When you see ST depression in the anterior leads, That could mean a posterior STEMI. A 15-lead ECG can help determine whether there is a posterior STEMI or not. These R waves in the anterior leads may actually suggest a Q wave on the posterior side. Congratulations! You've reached the end of the intervals ECG set. You're now ready for the final ECG. It's time to put it all together. In today's workshop, we've practiced ECG sets from 3 categories: features, waves, and intervals. The goal was to draw your attention to various aspects of the ECG to review implications of their abnormalities. In practice, you can tackle the ECG in any order you want, as long as you are systematic about it. If it works for you, you can even try tackling features first, then waves next, and finally intervals. Or perhaps another method you've picked up along the way. For this final ECG exercise, using any approach of ECG that you would like, please identify all the findings you can in this ECG. Pause the video to work on this independently, identifying as many things as you can. Enjoy, have fun, good luck, and let's review the answers once you're done. Please pause the video now. Hello and welcome back. Let's review the final ECG. We have a 65-year-old man with retrosternal chest pain on exertion radiating to bilateral arms associated with nausea and vomiting and diaphoresis. Yikes, the history itself is concerning for a cardiac issue. Let's look at the rate. The ventricular rate is 47. I'm getting that by counting 7 QRS complexes in this 10-second strip. 7 times 6 is 42. The atrial rate, I'm getting 75. 300 divided by 4 large boxes between P waves gives me a rate of 75. The ventricular rate and atrial rate are not the same. This suggests to me a 3rd-degree heart block. There are P waves marching through the QRS. So there's 4 big boxes between each P wave. So this is a P wave, then roughly 1, 2, 3, 4, this is another P wave. 1, 2, 3, 4, a P wave is hidden here. 1, 2, 3, 4 boxes is another P wave. 1, 2, 3, 4 boxes, another P wave. 1, 2, 3, 4 boxes, another P wave. Let's look at axis. It's a normal axis. AVF is pointing upright, and 1 is overall pointing upright. It's kind of hard to tell, maybe isoelectric, so I'm going to use lead 2 to help me out. Lead 2 is pointing upright. I know that on that axis circle, lead 2 points towards the bottom right, with 1, 2, and AVF all kind of pointing upright. The net effect is pointing towards the normal axis. Let's look at waves. The P wave looks okay. It doesn't look majorly tall. It doesn't look majorly too wide. The Q waves, I see a Q wave in 3, and I see a Q wave in AVF a little bit. The QRS itself overall has kind of a low voltage. Moving on to the T wave. The T wave is fused with the ST elevation in AVF and 3. There are some T wave inversions, particularly in 1 and AVL, because it's fused with the ST depressions. I don't identify any obvious U waves. In terms of intervals, the PR intervals vary, which is consistent with a 3rd-degree heart block. PR gets longer for Wenckebach, PR stays constant for Mobitz type 2, and PR varies for 3rd-degree heart blocks. The QRS looks wide here. And why is that? Oh, because I see bunny ears. Boom, 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 bunny ears in this right bundle branch block pattern. ST, we see an inferior STEMI, 2, 3 AVF, with ST depression in 1, AVL, V5, and V6. And the QT to me looks okay. And this is just a summary slide of what we discussed on the final ECG. That pretty much wraps things up, folks. Thanks everyone for participating in this workshop here today. Remember that your feedback is really important. It'll help us improve the session, your facilitators, and your med school experience. It's been a pleasure reviewing ECGs with you. I hope you had a good review, picked up a few new tips and tricks, and now you're ready to save lives. Goodbye.